And it's my great pleasure to introduce Michael Markl to you. Michael comes from Freiburg and worked there with Jürgen Hennig. He's been doing a lot of fascinating work in MR, but one particularly exciting area that relates to our interests is being able to measure flow in 3 dimensions as a function of the cardiac cycle. It's really a computational fluid dynamicist's dream, and in fact it looks like it's becoming our dream, because if we really understand the flow into and out of the brain, we may be able to understand the role of abnormal jugular flow. So with that, Michael, we're looking very much forward to your talk.
Well, thank you very much. First of all, I'd like the organizers and Mark to give me the opportunity to present some of our work here. And I have been given this very bold title, The Future of 4D Imaging of Flow, so I'm kind of hoping that I can live up to it. I'll kind of switch gears a little bit in terms of what you've heard from the previous talk. I'll talk a little bit about cardiovascular MRI. That's where I come from. I'll show some examples on how to apply these new techniques that I'll introduce in a second to the cardiac and vascular system, but then I'll also move to cerebral and intracranial flow analysis. Just to remind you, and as I think you've seen this in a number of talks in this conference already, that MRI is quite a versatile technique, actually. It can provide you information on function, morphology, and so on. And these days we can even look at the vascular system really from head to toe. But the really unique advantage that MRI offers is that on top of morphology and anatomy, we can really look at underlying physiological processes, such as perfusion, diffusion, or as I will talk about, flow. And since we're talking about the future of 4D flow imaging, I just want to take one step back and look a little bit at the history of how flow imaging and MRI evolves. And if you look at the literature, it's actually not a new technique at all. As early as 1916, Erwin Hahn actually realized that you could use the MR imaging process, or at that time it was more spectroscopy, to actually interrogate the MR signal to get information on flow. And already in the early 80s, late 80s, early 90s, there were first human applications to 4D flow imaging. And that's what we actually still do today, if you think about it. If you have an MR scanner to your disposal, there's standard 2D phase contrast of flow imaging, looks like this. So you typically place a slice transecting the vessel of interest. Here would be the thoracic aorta. And then you can get time-resolved images. Here you're seeing the pulsatile motion of the ascending aorta and to a lesser extent the descending aorta. But at the same time, you can acquire spatially and temporally co-registered images of blood flow velocities. Here white means flow is coming towards you, black meaning flowing away from you. Very much similar to the information you would be used to from echocardiography, Doppler echocardiography. Here we're interrogating flow through the imaging plane. And of course you can then go into the data, draw regions of interest on the vessel that you're interested in, and arrive at quantification of blood flow, which is routinely used clinically these days with MRI to determine such parameters as peak velocities, regurgitant fractions, net flow, stroke volume, and so on. So that's what's available clinically on routine systems. So what we and others have done in recent years is to take this one step further by really utilizing all the capabilities MR has. So we can image in 3 dimensions. At the same time, we can synchronize the measurement with the cardiac cycle to get information about function, like here in the heart. And as you've just seen, we can image blood flow velocities. But as opposed to echocardiography, we cannot only do this along one direction toward the ultrasound probe. We can actually interrogate 3-directional blood flow velocities. And all these capabilities taken together is something is a method that we've developed. I've entitled 4D flow MRI. 4D because we're looking at 3D volumes over time. So from a physicist's point of view, which I am, so that's a 4-dimensional space-time. And flow, of course, because we measure the 3-directional velocities. Of course, it's a lot of data that you actually have to acquire with these techniques. And typically what we can these days is image, and I'm showing here an example of the thoracic aorta. I promise I'll move towards the brain a little later. And we get spatial resolutions on the order of 2 millimeters, temporal resolutions of 40 milliseconds. And we can do this in scan times of 10 to 20 minutes. And the information you then acquire is shown here. So you get an anatomical image, Actually, it's a 3D volume, but over time, so you can see the beating of the heart, pulsating of the aorta. But at the same time, you get velocity information along all three spatial directions, Z, Y, and X. And it's very clear that there's a lot of information contained in that, but on the other hand, it's very difficult, at least in my mind, to combine all that into an image that makes a lot of sense. So a lot of effort by us and others has going into how to take this data, translate it into something that's visually more easy to appreciate and also can be evaluated quantitatively. The first thing you can do is you can load this data into a visualization package and calculate an angiogram from the data. So you get this angiogram essentially for free without the use of contrast agent, but then in the next step you can actually visualize the blood flow that was acquired with this technique. What you're looking at here is so-called time-resolved 3D path lines or particle traces. So we position two emitter planes here and here, and then we release virtual particles that trace the measured time-resolved three-directional blood flow velocities over time. Color coding here reflects to the velocity magnitude, so red is fast, blue is slow. And I think you can nicely see how the blood leaves the heart, goes into the ascending aorta, into the brain-feeding arteries, and so on. And that, of course, can be applied not only as in this healthy volunteer as shown here, but also in the presence of disease. And here I'm showing an example, assuming it will play in a second, of a patient with a bicuspid aortic valve. So instead of the tricuspid valve, it's a bicuspid. And you can see the flow is dramatically changed as opposed to what you've seen before. So you see this swirling motion, wild distribution of velocities. But keep in mind at the same time we can go in retrospectively after the scan at any location in this data set and quantify flow. And here you see pulsatile flow time curves. And if you look at these numbers here, they become negative. So this is indicative of retrograde flow or regurgitation in this patient. So taken together, I mean, we now have a possibility to not only in 2 dimensions, but really in 3D or 4D, if you like, to look at the distribution of blood flow in entire vessels of interest. And again, here I'm showing an example of a normal control and a patient with this bicuspid valve where you see this substantially altered flow patterns introduced by this deformed valve, potentially then linked to the dilation of aneurysms. The theory here is that these flow changes induce altered wall shear forces, which in turn will change endothelial cell function and then lead to remodeling. In this case, aneurysm formation. The idea is hopefully to have a tool available that can help us understand a little bit better what are the hemodynamic mechanisms in relative to disease progression in this particular patient. I just want to make it very clear once more here, what you're looking at here is not the results of a numerical simulation or computational fluid dynamics. It's the result of a measurement of the blood flow velocity in this particular volunteer and this particular patient. So we're really looking at the real thing within the vessel in this patient. Over the years, we have started to apply these techniques in different vascular territories. I just showed the aorta, whole heart imaging, also the brain. And in the remainder of this talk, I'd like to show some examples from 2 areas, whole heart imaging, where we start including the arterial and the venous part, and then kind of also some examples from intracranial 4D flow imaging to hopefully convince you that it's not just pretty pictures, but that there's actually some serious information content that can help us understand the development of disease. So first of all, I want to talk a little bit about whole heart 4D flow imaging. So we simply expand the volume beyond the aorta that you see before to really include all cardiac chambers and all feeding and draining vessels of the heart, if you like. This was quite a bit challenging in order to bring the scan time down to a level that's actually manageable in clinical reality. Currently we're at 15 to 20 minutes, which is still a bit long, but keep in mind there's really a lot of information you're getting from this data. And again, you can then visualize this information. At this point, it starts becoming really very complicated. And I'm showing here an example of a patient after the transpositions of the great arteries. So a patient that was born with switched aorta and pulmonary system. The surgeons then restored or moved the aorta to the left ventricle and the pulmonary to the right ventricle, leading to a pulmonary artery now in front of the aorta as opposed to the normal situation. Here I've color-coded the flow not according to velocity, but according to vascular origin. So yellow and orange flow originates in the left and right pulmonary veins. Blue flow originates in the pulmonary artery, and for some reason this stopped playing, so I'll try starting it again. And you can see that we're now able to really starting to understand very complex integrated systems showing kind of flow into the left atrium, in the left heart, out into the aorta, or here on the venous side, flow from the superior and inferior caval veins into the right atrium, into the ventricle, and then out into the pulmonary artery. So this gives us now the opportunity to really understand these complex alterations, and I show one example here in congenital heart disease of a 5-year-old patient with a very complicated history of disease and aortic repair. So this patient had started out with a hypoplastic left heart, got repaired. It has a double outlet of the left ventricle, so 2 arteries are coming out of the left ventricle. It's a transposition of great arteries, and the patient underwent a so-called total cavo-pulmonary connection, so we have a direct connection of the superior and inferior vena cava with the right and left pulmonary artery. And again, we can try and understand what's going on in these patients with this technique. And here I split up the flow on the arterial side here on the right and the venous side on the left. Again, it's one measurement, just the visualization is separated between the arterial and venous side. And I think you can again nicely see, and again, remember this is now a single ventricle patient, so we're going from a typical dual heart system that we all have in this patient to a single serial system where the venous flow returns directly from the caval veins into the pulmonary artery. And again, as said earlier, the technique is also quantitative. So after the fact, after the imaging, we can really go in at any location we're interested in and look at things like peak velocities, flow curves over time here on the arterial side, or, which is of interest here to the vascular surgeons for these type of connections, is how well does the connection that directly integrates venous flow or that leads venous flow to the left and right lungs. How well does that work? How much flow is going to the left and right lung? And it's quite interesting. If you look at this, it seems as the flow from both the superior and inferior caval veins goes to the right and left pulmonary artery in a quite kind of consistent way. But if you actually quantify it, you see that there is a flow ratio of almost 2. So much more flow is actually going to the right lung than to the left lung. So this now gives you an opportunity to really not only look at individual flow values as with standard techniques, but to understand the system as a whole, if you like. And we've done some initial studies where we compared different types of surgeries. These are different patients with kind of the same surgical connections, and we looked at the flow patterns in all of these. And the interesting part here was that all these connections look geometrically very similar, but the flow is very different between all of these patients. And that kind of tells you that geometry alone or simple geometric markers may not be sufficient to really understand what's going on hemodynamically in such a complex system. Next, I want to move to a vascular region that's probably closer to people in this audience, to intracranial blood flow. This is an example where we took the technique and moved it to the brain. Because we can have smaller volumes and so on, so we're now able to do these measurements with spatial resolutions of the order of 1 to 1.5 millimeters. So we're not there yet to interrogate the very small vessels, but we can look at the larger vessels, and here you, I think, very nicely see the flow in the circle of Willis, and that we can really follow these very complex pathways of flow here through the carotid arteries and throughout the entire brain. And we've started to apply this. And it's actually quite striking that it works relatively well to patients with AVMs, arteriovenous malformations. And here you can see, if you keep the volunteer in mind, that the situation is dramatically different. You have this very complex, intertwined system of vessels, and it's almost very hard to make sense of it. Again, I want to caution with respect to results we're seeing. We can look at the larger vessels. We don't see the very small vessels. Nevertheless, you see that all of a sudden you not only see the anatomy, but you can really look at the distribution of the velocities within the complex system. And more so, what's more interesting to us in this case is not only that we can visualize it, but we can follow up these patients over time. And here I show an example where the patient you just in the previous time, we followed these patients throughout staged embolization. So the neurosurgeons went in, closed off some individual vessels. And you can really nicely see in this case how this complex AVM compacts with more and more surgical interventions, and also how the velocity distribution changes with inside the AVM. And by the way, also in the venous system, which you can very nicely see here. So in the transverse sinus here, you see that from very high velocity, you go to much lower velocities when you start treating this AVM here. So again, it gives you an opportunity to look really at the systemic impact, if you like, of a local embolization. And again, we can go in at any location of interest and quantify flow. And here we look at peak velocity at baseline after the first embolization and after the second, for feeding artery of the AVM, for a draining vein, for flow on the contralateral side, and in the sagittal sinus. And interestingly, for example, you can see that the flow on the contralateral side went up after the first embolization and then down again. It kind of tells you a little bit about the unpredictability of these diseases and what happens when you treat them. And hopefully we'll have a method at hand that will help us to understand a little better what's really going on and help the surgeon plan the intervention a little better. In terms of interventional planning, there's some other ideas out there. This is again an AVM that we recently imaged, and you can see it's almost, I mean, I find it very difficult to understand what's really going on. So we thought about how we could make a little bit more sense of that. And one idea we had is that we do some kind of virtual tagging of individual feeding arteries, and that's shown here. Again, this is not a simulation. We've measured the blood flow in this patient, and we just release the streamlines that show the time-resolved evolution of blood flow in these vessels from different vascular origin, and can then nicely visualize individual feeding and draining patterns are shown here side by side, where we can see that this feeding artery is mostly responsible for flow in this vascular region, whereas this one is kind of feeding a smaller area, and this one, this part. And you can also then identify individual draining patterns. So what about venous flow? We've heard a lot about venous flow. Our group, we ourselves haven't looked much at venous flow, but there are other groups out there, and particularly the group from University of Wisconsin-Madison has done some very good work, I think, in this area. And the next couple of slides were brought to me by Oliver Wieben and Kevin Johnston from UW-Madison. And they've actually focused on some methodological development on a new imaging technique they call PC Viper, and I don't want to go into detail, but it allows them actually to really drive the spatial resolution to sub-millimeter resolution, and that's, I think, the key here. And I'm just showing an angiogram they derive from that data. And as you've seen throughout the day, I mean, it's of course, this is not higher resolution than the time-of-flight images Dr. Hackey was showing earlier, but the key here is that in addition to the angiogram, you can have information about hemodynamics in the venous system, and I'm just showing some sample images here of flow in the sagittal and transverse sinus. And again, you can then go in at any location you like and look at flow patterns, velocities, and so on. And with the high resolution, the technique is to hope that you really can get information on both anatomy, arterial and venous, at the same time visualize flow direction for different venous parts, and then quantify flow over the cardiac cycle. So I think there's a real opportunity here, not only to look at individual part of the system, but look at the intracranial, arterial and venous system as a whole. Same is true, of course, for the cervical system. Here I show an example, again, the angiogram, and then flow in the carotid artery and the jugular vein. And here the color coding is actually not only vessel system, it's color coding according to the flow direction. So you can actually use the information on flow you have to identify different directions of flow, or again, as shown previously, visualize the flow with these streamlines. And here the color has a different meaning. Again, it reflects blood flow velocity, or going in and really, and here they've gone from individual planes to just central lines along the vessel, where you can look at peak velocity and how it develops along the course of the jugular vein in this example. Just briefly, I've talked about whole heart imaging, intracranial flow. Of course, there's other options to apply this technique. Just a couple of examples here in the carotid bifurcation. Normal volunteer, you see the typical flow here in the bulb with some kind of swirling flow, which is much enhanced in a patient here with carotid artery stenosis. So you can't see the plaque here, but you see the narrow lumen and kind of the massive or enhanced swirling motion here distal to the stenosis, indicating again altered wall shear forces that are hypothesized to impact endothelial cell function. And the idea is then that these flow patterns indicate the direction the plaque will grow. And interestingly, here's a patient after recanalization. You can see that the flow patterns have actually nicely been restored. So again, the hope here is, on top of information on anatomy and morphology, we hope to get some information on hemodynamic outcome. Did the surgical intervention not only regenerate the anatomy, but also the hemodynamics? Other example I just want to briefly show we've been working on is portal venous flow. So you can see the portal venous system. Again, interest here is in hypertension, flow reversal. Can we understand better what's going on in the portal or also arterial system of the liver? And finally, just one more example in the peripheral arteries. Here, the abdominal aorta branching into the iliac and femoral arteries. I think you can nicely see the triphasic flow going forward, backward, and forward here that we're able to depict with this. Before I come to an end, just a couple of words on where I think we should go from here. I mean, there's two problems we have with this technique. One is really long acquisition times, and the second one, or I should say challenges. One is the long acquisition time, and the second one is the rather time-intensive data analysis. There have been, and as mentioned before, there have been lots of efforts in bringing parallel imaging to the table. And actually the 4D flow imaging technique lends itself almost ideally to parallel imaging because it acquires data in multiple dimensions that can be undersampled. And without going into detail, we've explored some techniques that we believe can bring us to very high acceleration factors. That's just a comparison of different applications here, so that hopefully in the future we'll be able to do this imaging not in like 10 to 20 minutes, but more like 4 to 8 minutes or something along that line. In addition to that, another very important aspect of the data I've shown flow visualization and quantification, but there's much more information that can actually be gained from the data. So we have information about 3D anatomy and flow, and through modeling, and here I'm showing one example, we can, for example, extract 3D pressure fields from the data by making certain assumptions, and then use the technique to, I think I've just lost the signal. Anyway, okay, then I'm back. And we can hopefully use the technique to really, on top of the information that I already showed you, provide additional information on hemodynamics and function. And this is one example how I think this could look like. And again, this is all derived from the same single data set, and you can then selectively switch between anatomy, here looking at the coarctation and post-stenotic dilatation, flow, and in this case pressure difference maps that show a pressure gradient across the stenosis here in the aorta, or an example that was again lent to me by Oliver Wieben from Madison, looking at the stenosis here in the transverse sinus, and again flow pattern here, and pressure maps here that show a transstenotic pressure gradient greater 5 millimeters of mercury, and very high flow velocities through this stenosis. There's actually been a lot of work going on in this field over the past years. I could only touch on a couple of new ideas for quantifying the underlying hemodynamic information. There's a lot of literature out there. If you look in Medline on the 4D flow derived quantities, you'll find a lot, and I really didn't have the time to cover all of that. I just wanted to acknowledge that there's a lot of other groups out there that have been active, not only in developing the imaging technology, but also looking at the processing, advanced processing at that data. So in summary, I think we now have a method at hand that can help us to really look at cardiovascular disease and therapy from a different angle. We have all this information about 3D or 4D volumes, so we can really try to understand what's the systemic impact of a disease, not only by focusing on an individual vessel area, but by looking at the system as a whole. What's still missing is really the translation of that technology into a clinical environment, which will require, and I touched a little bit about that, simplifying the MR acquisition, but also, and that's one major point, really taking those rather complicated analysis tools and making it very simple so that it can be really integrated into a routine clinical environment. And finally, I'd like to thank all my collaborators and again the organizers for inviting me, and of course you for your attention.
Thank you very much, Michael. This is really an exciting direction, and I think you've probably heard enough talks here to know that when you got up into that intracranial region, that was really getting closer to our heart. And the ability for us to study the fluid flow here is going to answer, I think, a lot of questions that people have been posing. And the floor is open for questions. Bart?
I have two questions. First is, you compare this with the PC Viper, which the acronym says vastly undersampled. Does this mean that with PC Viper you can't put the cut planes arbitrarily, the streamline planes arbitrarily?
That's a very good question. So it means vastly undersampled, but it's still a 3D imaging technique. So the cut planes are, positioning is that's independent of the imaging technique you do. For both the Cartesian technique I started out with and the Viper technique, you acquire volumetric data and you're very free in the post-processing.
Okay. And now the second question is with a 20 to 30 minute acquisition, what do you do about motion, head motion registration?
Yeah, that's a very good question. Currently we really don't do anything about that. For thoracic applications, we use navigator gating to synchronize the measurement with the respiration cycle. You could think about something similar, putting a navigator at some part of the brain and tracking the motion and correcting for it. We haven't done it, but that's a very good point, particularly if we're interested in very small vessels, then we'll probably have to think about that. Currently, with the resolution we have and the larger vessels, I don't think it's a big issue, unless, of course, there's severe patient motion. But for smaller vessels, that will be something that has to be implemented.
Bart, just to answer your first question a little further, it's not vastly undersampled in the spatial domain, it's in K-space. So then back in the spatial domain, you still have the full 3 dimensions through which to look at it.
All right, so we'll move on to the next presentation, and I guess the next speaker doesn't really need any introduction. I'll do it anyway. So Dr. Hackey will talk about flow characteristics in the study of 300 MS patients, and he mentioned earlier that he has some really exciting results to present, so we're all looking forward to his talk.
Thank you very much. I wish I had that 4D data to show here with this. It would even make it more convincing. So I want to talk really about possible biomarkers based on quantitative flow. And I'm going to start off by talking about 300 MS patients and show one flow biomarker and then work to show a second biomarker. This is my conflict of interest statement and acknowledgement again to all of those who have helped. So the goal of this study is to examine the extracranial flow characteristics using MRI, especially the internal jugular flow, but measuring all flow from measurements in the neck into and out of the head in order to identify risk factors or potential biomarkers associated with venous flow, in this case, in the first part, in the MS population. So we have 300 MS subjects that were recruited at applied fMRI. 22 were excluded due to degraded flow imaging quality, so 278 cases are presented here. This is an approved IRB study with written informed consent. The MR imaging was basically something like our core CCSVI that we spoke about. We have time-resolved, contrast-enhanced MRA and time-of-flight MRV. And then 2D phase contrast, time-resolved, so not quite the 3D that we saw here. These are the imaging parameters, but I think that I just wanted to draw your attention here to the resolution. We try to do as high resolution in plane as possible, so roughly 0.6 by 0.6 millimeters, because when you have small vessels, you need very high resolution to quantify the area accurately. So we've looked at this generally at 3 different areas, C2, C5, C6, C7, T1. This is going to be around C6 where I'm going to present the flow data. And of course, one can use the cross-sectional information to get the velocities. But we can also use the cross-sectional information to get stenosis. So I just point out here, because I'm going to break this up into non-stenotic and stenotic MS cases as well, that there are a lot of stenosis present here at different levels in these patients. And you can see here, for example, 51 unilateral C6 stenosis, or 36% of the patients. And you can see the variation from the different levels here. So for the phase contrast, we take, in this case, just one transverse slice, but I can take my time and cardiac gate it. We still use parallel imaging, of course, to get that high in-plane resolution. And we can draw the cross-sections for the arteries, which are red in this case, and the veins, which are blue. And we take that data, and in this case, after quantifying the flow, we plot the total arterial flow in milliliters per second versus the internal jugular flow normalized to the total arterial flow. And I think this is very important because you could do that with ultrasound as well. So in principle, much of the data that Dr. Zamboni has collected or Dr. Hu has collected, especially with the registry that Dr. Hu has of several hundred patients, they could go and also create this plot. So let me explain carefully what this is, because I don't want you going away thinking I just showed you some complicated thing that doesn't have a simple interpretation, because it really does. All of these solid filled symbols represent MS patients who have stenosis. All of the open symbols represent MS patients who don't have stenosis on MR, at least. Now you can see that if the flow is less than 50%, if the total internal jugular venous flow normalized to the arterial flow is less than 50%, I see mostly stenotic cases. Of course, that's not surprising, because if they're stenotic, you would think they're not going to get a lot of flow out of them. Now, that's not necessarily true. If you have a slight narrowing of a carotid artery, for example, say only 50%, the total flow through there, in fact, is often conserved. The flow increases, the speed of the flow increases in the narrowed area, and then it decreases again outside, and the total flow is conserved. It's only when you get rather severe stenosis that you have a problem. So the green symbols represent about 25 normal controls. You can see that the green symbols lie mostly, except for one, above that 50 percentile. So let's take a look at that. So if we can do hundreds of normals and they all sit above that mark, then we have a very strong quantitative marker. Now, Dup's paper breaks it into three parts. So he looks at the upper third, the middle third, and the lower third. Well, if I only focus on the lower third, and you can see there are no normals. So having low flow here suggests that you're going to have stenosis and suggests that you have abnormal venous flow compared to normal controls. So I also want to talk about the ratio of the dominant to subdominant flow, because many MS patients, we can see from the contrast-enhanced images, many veins. We can see the external, the internal, we can see the anterior jugulars, the deep cervical veins, the vertebral veins, and the vertebral plexus. But often when we do the flow measurements, there's still only one vein that carries out most of the flow. So these other vessels are not really functioning as they are in normal controls. So the anatomical information is important to guide us. The functional information is critical in deciding whether the types of hemodynamic flow that Michael was talking about are really normal or not. So I'm going to look at this ratio as being 4-to-1 as being abnormal. There is actually evidence from surgical conditions where patients have to keep their head tilted like this, that those patients who have flows in one jugular vein greater than 3-to-1 suffer stroke, suffer cognitive problems, and all that happens in just 4 hours. So I think this could be an important biomarker for us as well. So we looked at 30 Parkinson's cases. 29 we were able to analyze. The range, 36 to 76 years, mean age 61, standard deviation 9.5. 16 males, 13 females. Symptoms included hand shaking, leg shaking, bilateral pain, swelling of limbs, weakness of limbs. The UPDRS score was ranged between 8 and 56. We had 24 of these had flare data, and 12 of these show white matter abnormalities. This is an example of somebody who shows white matter abnormalities. So what do we see? I'm just going to show you a few cases here. I'm going to show you those 10 cases that are dominated basically, 9 cases, dominated by only one vessel. So even though you may see multiple veins here, the work is being done basically by one vessel. So you can see here in the very first case that you have this banding artifact present here in a 2D time of flight. And of course, we know that that represents very low flow. If we look at the integrated flow here, you can see it's dominated by the right internal jugular vein with very low flow in the other veins. A second case, here you can see the same sort of thing. Sorry, take my glasses off. I can't see well close up with them. You can see dominated again by the right internal jugular vein with about 1 milliliter a second in the left in this case. This third case is very interesting. You may have noticed, although I didn't really focus on it, that it's very hard to see the left transverse sinus in these patients. Here you can see that, in fact, there isn't a conventional left transverse sinus. You have multiple veins feeding into a reconstituted jugular vein on this side. Well, look, I see it just fine in the contrast-enhanced images. It has very low flow. It's dominated again by the right-hand side. Another example here showing a complicated structure, many veins, dominated again by the right-hand side. Now here you see some evidence for a transverse sinus, but not significant evidence here. This could be because this is 2D time of flight, and it's possible I'm not seeing this very well. However, whether or not I see it, you can see this is again completely dominated by the right-hand side. In this case, I can't see evidence for a transverse sinus, dominated by the right-hand side. Similar situation again for this ninth case, dominated by the right-hand side. Now you can see that all of these are basically looking very similar. They're lacking complete connections with the transverse sinus, or there is no transverse sinus, perhaps a congenital problem. They have complicated structure on the left-hand side of the brain. Another example here where there is a jugular vein reconstituted, basically no flow in that jugular vein. And finally, the last two cases. So case 17, similar situation to some of the others we saw before. There's a stump of the jugular here. There's no flow in that jugular. So I've just shown you 9 cases out of 18 cases that show abnormal flow on the left side of the brain. Here you can see the transverse sinus quite well in this particular case. So the 21st patient. And here they have wonderfully normal, equal internal jugular venous flow. So what we've seen here is that in 29 cases, 18 of these cases have potentially missing left transverse sinus or slow flow in the left transverse sinus, and therefore abnormal flow in the left internal jugular vein. Of 25 normal controls, only 4 show types similar to this behavior. So I want to close by showing you the quantitative data associated with all of this. I'm going to start with Dup's original ultrasound data, where he shows that the upper third, i.e. those cases where the jugular veins carry 2/3 or more flow from the brain, 72% of the population has that feature. 22% has it only in the middle third, and 6% in the lower third. If we look at the data that we have from Wayne State University for 25 normals, we get 60% here, 36% here, and 4% here. Very similar to what we see with DUP. And if we look at the data from Wuhan Union Hospital, which is where the Parkinson's data comes from, we see we get 48% here and 52% here. Very different than the normal population that we see. And the final plot, although complicated, I think is a summary of all our quantitative knowledge of what's going on in flow. So I'm going to pretty much close with this slide. And again, let me describe to you that all of these solid-filled symbols represent those MS patients that have stenosis. And you can see that many of these MS patients here lie below this line of 4:1. The open symbols, which you'll notice mostly lie up in this region with this value greater than 0.5, this normalized value, where the internal jugular venous flow is now greater than 50% of the total arterial flow, they're all open circles. Now, what about the normals? Where do they sit? Well, the normals sit in this region, and there are a few normals here that are below 4:1. And there's one normal here that falls below this that I showed you before. So this technical plot, this characterization of dominant jugular flow versus subdominant jugular flow, the sum of which represents a constant flow along this line, may be 2 strong indicators for the potential for neurodegenerative disease, or in this particular case, for multiple sclerosis or Parkinson's. The multiple sclerosis cases have about 25% of the population lying below that 50% mark. The normals, only 4%. In the ratio of 4:1 for the dominant to subdominant, we have 10 out of the Parkinson's cases sit in this domain, greater than 4:1, and we have only 4 of the normals, so 16% of normals show that characterization. So at the moment, most normals sit up in this region right here, which means if we can collect data on several hundred or 1,000 normals and demonstrate that for the most part, the predominance of normal people sit within this flow range, and show that only a very small percentage of people lie in this range, people who in fact could perhaps later go on and develop neurodegenerative disease, then we would have a very strong biomarker for the development of abnormal flow. Now, there is one way that we could test this today without waiting 30 years to see what happens to these 4 people. And that is, if we image a set of elderly people in the same way we did here, and no elderly people who are healthy fall below this line, and no elderly people who are healthy have a dominant to subdominant ratio of greater than 4:1, then this would be an indirect evidence that all those people who do are going to go on and develop neurodegenerative disease. So we have a lot of quantitative data from which we can work today. I've summarized in this plot the number of cases at each of these sites that represent total flow being less than 50%, or this ratio being greater than 4:1. One can also combine or look at the intersection of these, and what we find for the MS data is that roughly 40% lie here at the intersection. For the Wuhan Union Hospital and the Parkinson's, 44%, and for the Wayne State University normal controls, only 24%. So the numbers here need to be increased, but it's quite clear that there are statistical differences between all of these cases, and this may end up being true for some of the other diseases that are being studied, like intracranial hypertension, exertional headache, and a number of other diseases. We haven't investigated dementia at this point, but I think with everything that's been shown here today, we have the potential to quantify this data and come up with biomarkers of what's happening in these diseases. So, in conclusion, quantitative analysis really perhaps provides the potential to subcharacterize the MS population. We can separate things from low flow and high flow, and those dominated by one vessel or one jugular. And as I said, many more controls need to be done. Thank you very much.
Thank you very much for this fascinating update on the latest results on flow in MS and Parkinson's patients. The paper's open for discussion. Please.
So I promised you I was going to push you on this. So 300 of those are from our center, and then we have maybe 30 normals. I would say that all of those patients have combined IJV flow of less than 7 to 8 milliliters per cardiac cycle. And all of our normals have combined internal jugular at C6 of 8 to 16. So I think you could go farther than what you've gone so far and say that we're not that far from a quantitative number of what's abnormal and what's not.
So the numbers you quote are actually very similar to this. I used 50%, but it turns out that if the arterial flow is 16 milliliters per second, then 50% is in fact 8 milliliters a second. So on the safe side, if you choose 7 milliliters a second, assuming you believe the absolute measurements, and I think that's why I quoted this as a ratio, we initially had plotted this as 7, 8 milliliters a second. But the problem is you have variations from site to site, you have variations from ultrasound to MR, so if you normalize this data to the total arterial flow, you get rid of some of those variations. So if you believe your quantitative values, then probably 7 to 8 milliliters a second is equivalent to the 50% that I suggested. Yeah, that's correct.
Solve all this debate we've been having for 4 days about collaterals and stenosis size and percentages. If we could actually say combined IJ flow is a quantitative number, then all these other issues become less problematic.
Well, it's certainly suggestive, but I think what would be ideal would be to compare these measures, as Robert Zavadinov was suggesting, looking at collateral flow and how it helps improve the comparison with MS, because you're probably going to find that those patients who have the most collateral flow, as you can measure from major vessels, will be the ones that fall below this 50% mark. And that has to be demonstrated at this point. So, we have something to aim for. We've had a puzzle to attack. We've just didn't know exactly what was happening in this puzzle. Now we've bought the puzzle. We have a good idea what the components of the puzzle are. It's time to put those pieces together. Thank you.
Are there any more questions?
Oh, I guess it's my turn. No, so we'll go on to the next presentation. And, of course, Paolo needs no introduction except to mention that he's going to talk about postural control of cerebral venous return in normal and CCSVI subjects. Paolo.
Thank you. Thank you, Marco, also for your amazing, very interesting data. We are talking about the postural control of cerebral venous return. As we listen along this day, IAS and VD meeting, both MRI and echo-color Doppler techniques are not completely satisfying our needs for screening and for measure the cerebral venous return. And this generated considerable and scientific controversy linked with the diagnosis and screening of the condition known as CCSVI. Aim of this study is to assess the cerebral venous return in relation to the change in posture by the means of a novel cervical plethysmography method. You know that we spend more than 2/3 of our time in upright position, and this is highly favorable for cerebral venous return because in this position there is a negative hydrostatic pressure value and there is a column of approximately 30 millimeters of mercury between the parenchymal veins and the base of the neck. So you may easily see that if you change in posture and you measure the cross-sectional area by a B-mode equipment, you have a progressive enlargement and bypassing from upright to the supine position. And this is due to the fact that when you are in upright, you have a negative hydrostatic pressure component, so the external component of the atmospheric pressure become dominant and the jugular vein collapse. This is also very interesting because it may give us further assessment, for example, of the jugular vein compliance, because this simple test represents a rough estimation of the jugular vein compliance because the cross-sectional area reflects the content in volume of blood volume of the jugular vein, and of course it is very easy to measure the hydrostatic pressure by the means of simple metrics. If you look to literature, even though CCSVI was not found anymore like in the Deep paper, you see that when Deep and co-authors tilted the patient from the supine to upright position, they measure in MS patients an outflow of 173 milliliter per minute on average, and in controls a very big difference of 362. This is also confirmed by other studies. You may see, for example, the study of Monti, the difference between the outflow measured in both vertebral and jugular vein in sitting position and in supine position accounts for about 500 600 milliliter per minute in controls, and in MS is practically equal to 0 or less than 0. So this suggests us that we may quantify globally in a more precise way, because it's just instantaneous measurement, the outflow and the postural control of the outflow by using a technique that is called plethysmography. Plethysmography make a sensor, it's a collar, very soft silicone collar with a liquid metal inserted in this collar. There are, of course, measures of proper size. You may encircle the neck. As the collar stretch, it both elongated or reduced according to the blood volume content in the neck. You have a reduced cross-sectional area of the liquid metal, and you have, of course, change in resistance in the electric circuit that is proportional to the amount of blood content in the neck. By monitoring change in the electric resistance of the circuit, it is possible to measure the variation of cerebral, of neck volume and of blood volume content. This is the test. This is the subject in upright. You may put it very rapidly in less than 2 seconds in supine posture, and you may easily see that you may have a venous volume that increase because the blood distends the jugular vein, and you have an increased volume, of course, and also you have a redistribution of the blood volume from the subdiaphragmatic part of the body to the superior, of the upper extremities. And rapidly, you may tilt again the patient in upright, and you have an ejection fraction volume and the residual volume fraction in the neck. This is the test. You may see the venous volume. We also added 2 metrics. One is the filling gradient, is the filling, the time required to reach 90% of the total volume of the neck, and also the empty gradient, that is the time required to drain 90% the volume in the required time. Patient population involved 40 healthy controls with mean age of 41.5 and 44 MS patients fulfilling the McDonald diagnostic criteria with mean age of 41. We performed on both populations a blind assessment with SCD screening for CCSVI, and we found 93% positive CCSVI in MS and 5% of positive CCSVI in healthy volunteers. Both groups blindly underwent to cervical plethysmography. These are the results. We subdivided our patient population in CCSVI positive, both including MS patient and controls patient positive at color Doppler screening, and no CCSVI patients or controls that were patient negative at ACD screening. And you may easily see that we found a very significant difference in different metrics among the 2 populations. Especially the filling gradient is about 0.9 in controls with respect to 1.50 in CCSVI positive patients. Very interesting, the residual volume is 0.5 in control respect to 1.40 in CCSVI patients. This means that there is more blood trapped in the neck in CCSVI positive patients. And also very interesting, the empty time and the empty gradient were significantly different. So, for example, the expelled volume, 90% of expelled volume is achieved in controls in a time that is approximately 3 times higher respect to CCSVI. So the metrics were very interesting, different among the 2 populations, and this is a ROC curve that represents the sensitivity and the specificity very easily of a cervical plethysmography. We are showing 2 different models. One is the interrupted line is just by using the empty time as just one parameter, and we found a concordant rate with respect color Doppler of 75, discordant rate of 24, the percentile tide is 0.7. If you should use three variables, it's more complex. You may increase the concordant rate to 84, but I think that probably is too much complex, and as a screening device, we may propose simply the model with one variable. Very interestingly, you may see that the sensitivity is quite good, and so this can be a good premise to propose this methodology as a rapid and inexpensive screening device. Really, the test is 5 minutes. However, if you analyze the data according to the three more important variables, the spelled volume, the empty time, and filling gradient, that reflects the test, you may see that some overlaps exist. And this can be a problem, of course. And so I asked the cooperation of Clive Becks, but unfortunately is not here because he fractured his fibula, but he worked actively in this sense, and he performed a mathematical analysis of the data through a very interesting system that is called principal component analysis, PCA. It's a mathematical technique developed in early 20th century, which uses an orthogonal transformation to convert sets of possibly correlated variables into a set of values of uncorrelated variable known as components. There are first, second, third component that can be measured. This figure shows you that the dynamic of the outflow changing the posture, changing the hydrostatic component, is quite variable. So look at the interrupted line in CCSVI patients respect to controls. This because, of course, we have a lot of different situations, different location of stenosis, different alternative route, different collateral circles, estrad intracranial anastomosis opened in a very subjective way. But by plotting, for example, the empty gradient with one of the metrics we used with the first PC component, you may easily see that possible to find, probably in the next studies, a cutoff for this patient. Look at the very good correlation found and constant correlation found plotting empty gradient with first principal component analysis. And you may easily see that all the CCSVI group is below the relationship found in controls. And also, if you look at the filling gradient, this is much steeper in CCSVI, and you plot this with the second principal component of a mathematical analysis, you may see that the majority of CCSVI patients are dispersed above that line. So this can be really used to differentiate CCSVI patients from controls. Take-at-home messages. Cervical plethysmography is a novel device for non-invasive, cost-effective, and reproducible assessment of cerebral venous retard. In CCSVI, a significant volume of blood is trapped in the neck because of increased residual volume fraction, while the time required to drain in the vertical position is significantly longer in CCSVI respect to controls. In a model 3 variable, cervical plethysmography seems to have a very good appreciable sensitivity to screen patients with CCSVI. Another potential use is of cervical plethysmography is to assess in the follow-up the results of endovascular procedure, because you may easily measure these metrics and to compare a long time. This is very useful because there is an increasing number of procedures all over the world, and more studies and more need to measure in the follow-up, because you cannot, of course, use venography, MRV, and also Doppler, which require about 1 hour to follow up patient a long time. So it could be proposable to use this method to follow up patient after an interventional procedure and to measure more in depth the patient with a positive screening in the follow-up. Thank you very much for your attention.
Paulo, thank you very much. I'm curious, have you done any of these same people using MR to see if you have either stenosis or flow abnormalities in the MR cases, which obviously wasn't seen in all of those patients that I showed in the previous talk? There were still half the patients still appeared in the normal range. I'd be curious to see if some of those patients that appeared in the normal range failed on this test, and you would have then called them still with CCSVI, even when we didn't see something with MR.
This is a very good question. The main difference is that we test in a condition of extreme stress, like sudden change in posture, sudden change by condition of the hydrostatic pressure, and you move the fluid in a very different way respect to fixed supine position of MRI. It could be useful to compare if some of these patients may have, for example, some metrics like the filling gradient or something like this that is not measurable by MRV and possibly is affected by the postural test and not in the flow quantification measured by MRI. This can be possible. We need to compare in the multimodal way to assess the cerebral venous return to understand this.
Nice.
Nice job, Paolo. Did you look how the Doppler in these patients corresponded to plethysmography?
Yes, it is exactly the ROC curve that I showed. So we have 75% of overlapping data. So 75 positive screening at color Doppler corresponded to positive plethysmography screening. We do not have the overlap for 25% of people. However, I think that to have both color Doppler and plethysmography positive, or color Doppler, plethysmography and MRV, I don't know, we need also to do this, may give a strong evidence that something is abnormal in the venous outflow of that particular patient.
Sal?
Did you have any postural hypotension? Did you control for blood pressure?
No, during the test, no. We measure heart rate and pressure with no significant changes by this test. Not during the test, because the test is very rapid, because the rotation of the chair is less than 2 seconds. So you do not have time to assess the blood pressure in that moment.
But what about it after they're upright? Did you measure then?
What?
Did you measure their blood pressure once they were upright?
Yes, it was not significantly different.
Not different.
Do
you think there might be some role for pharmacological hemodynamic intervention to separate normal from abnormal?
Yes, this can be done, I think. Could be a perspective. We may use vasodilator or something like this to see what happened. I don't know. This is, of course, possible because plethysmography is widely used by cardiologists to assess the effect of vasodilation. And there are a lot of studies published on circulation of a major
cardiovascular journal using this kind of assessment.
Thanks.
Thank you very much, Paulo.
Thank you. So we'll move on to the next presentation, which will be given by Dr. Tucker, and he will talk about a physics link between cerebrovenous reflux and venous hypertension, hypoxia, and sclerosis.
That date is odd. It should be today's date. I want to thank the organizers, Dr. Heka, Dr. Dake, for giving me the opportunity to talk today, and Dr. Zvadnov for urging me to offer this paper up to this particular show. I'm going to talk about a number of links that relate to fluid dynamics, and the focus here is going to be on the dynamics that occur when a series of periodically placed pulses in time fold back on themselves, and the consequent pressure distribution that occurs. Here I'm thinking particularly in the veins, of course. My disclosure is this was funded by my kids' inheritance. First I'll talk about superposition. Two pulses, one a reflux, one a direct pulse, and when they pass through one another, you get the summation, a simple summation of the pressures. If we have now a series of pulses, and this is a simple sine wave, whoops, that shouldn't have done that. How do I go back? Okay. Oh, I'm not going to be able to show that, unfortunately. We'll go on to the next slide. Oh, there it is. What we would find is a standing wave that occurs, and here I show a cylinder in which there is this is just not working. What do I do?
Use the mouse here. Let's see if we can get you back to where you belong. Okay. There you go. Now, you know what? Don't use the mouse. Just try using the down arrow here.
Okay.
Just the up-down arrow.
Yeah.
There you go.
Oh, there it goes. Okay. I'm an electrical engineer. I'm sorry, I don't know how to operate these things. We see in this now the pulse distribution, where we get these high points and low points and a node in the middle. So what this would represent, if it were a blood pressure, would be a region of hypertension separated by a relatively low pressure region. So if we consider now the case of a cylinder that is one wavelength long, one wavelength of the standing pressure wave, and that is going to be determined by the time for one cardiac cycle and the velocity of flow. So if I put this into motion, oh, it's not going to work there. Sometimes the mouse and sometimes not. The water flows downhill and fluids flow down a pressure gradient. So if the time when the pressure gradient is in one direction, the fluid flows that way, and if the pressure gradient is in the other direction, it flows the opposite way. So that's why we see the motion of these particles going back and forth. But another thing that's very important about this bit of physics is that if the gradient is steeper, that means that the velocity of the flow is going to be greater. And in math, there is a convention here where gradient of pressure is also called del P, if I upside down triangle. And I mention that here because I'm going to come back to it. Michael Markle mentioned Navier-Stokes equations, which I'll come back to in a moment. But does this happen in the real world, this back and forth flow? Well, here's graphics, the flow quantification graphics, courtesy of Mark Heka. And in the left side, the unobstructed side, we see relatively little flow back towards the heart. But in the obstructed right side of internal jugular, we see that there is substantial flow in the wrong direction, as we had shown you here. And then there is this flow in the outflow part of the cardiac cycle. And if you compare what the velocities are there, you can't really make out very well what the axes are, but this is about 5 centimeters per second, but it's 9 centimeters per second on the outflow side. What that tells me is that the pressure gradient to push that blood out is greater. That what is happening is the vein and the associated sinuses during the reflux part of the cycle, they're being pressurized. So it's built up extra pressure, and that has to be forced out during the outflow portion of the cycle. So it probably is associated with hypertensive region, and the increased flow toward the heart can only occur with that increased venous pressure. Now, another interesting part about this approach is that it really does not matter what the nature of the obstruction is. It might be a malformed valve or a flap or a misaligned vertebrae, any of the other types of obstructions that have been talked about in the last 2 days. Now I'm going to have a look at a tube that is 15 centimeters long, which is roughly the length of an internal jugular vein. And so coming out of the venules and flowing towards a blocked obstruction at the valve end of that internal jugular vein, we get a reflux. So we have 2 pulses flowing simultaneously through one another. And at this moment in the cardiac cycle, the pressure sum distribution from superposition would be like this. And so what we would see at that moment is substantial overpressure, but it's quite localized. Now I'm going to look at 4 different points in time in one cardiac cycle here. And what this shows me is that every half wavelength I'm going to get one of these localized regions of hypertension. And what's happening is that the reflux pulse goes through, in this case, the following pulse, and in this case, the pulse behind that. So if you imagine 15 centimeters, average flow maybe 15 centimeters per second. So it takes about 1 second to go out of the venule, hit the valve, another second to come back up. But if pulse rate's about 60 pulses per minute, or 1 pulse per second, what's happening right up here in the venules is going to be this superposition of these pulses. And that area, of course, is a very tender area, and probably not a good idea to have hypertension there. So, how consistent with symptoms of MS is that? Well, Schelling commented that the number of lesions and the sizes of those lesions increases going in the counterflow direction, in other words, going back up into the venules, and that is consistent with an increasing pressure gradient that we see associated with that combined pulse. Another key thing here is that the distance between the obstruction to the venules needs to be an integral number of half wavelengths. So you can imagine a situation where a patient has reflux, measurable reflux, but the distance between the cause of the reflux, the obstruction, and the venules does not meet that half wavelength criteria. So you can have people with reflux that are not MS patients, don't have the lesions because there is no hypertension in that venular region. Now, bear in mind, too, that as one grows older, as one exercises and so on, the pulse rate does change. So that position of that hypertensive region is going to shift around back and forth. Other point, I guess, is that if you have a blockage, for example, in the azagus, it may be that it's not 2 half wavelengths, it may be 6 half wavelengths, but still that phenomena of accumulation of these pulses would still occur. Now here is a diagram, simple diagram of the capillary bed, or capillary bed. Being Canadian, I can do a translation between English and American. The blood that flows in, of course, flows out in the normal case, and it flows in rich with nutrients, oxygen, glucose, and so on. And as it passes through the capillary bed, those nutrients are transported across the blood-brain barrier into the cerebral tissue. So if there is an obstruction, it will do two things. It'll create a pressure distribution, as I've shown here, which is also, given that the vein is compliant, the vein itself is going to change its shape, given if it's in a hypertensive point or in a node point. But key thing here is that that blockage will cause the pressure on the output of the capillary to increase, but the input side is going to remain constant. So that means that the pressure drop across the capillary has actually decreased. That implies, just like a siphon, that if you raise the draining end of a siphon up to the input end, you'll eventually slow the drain down until it eventually stops. So the blood flow is going to decrease through the capillary bed. That's associated with the venial hypertension up at the sinus and venial end of the capillary bed. Also calling on Franz Schelling's work, he talked about a striking widening of the venous passageways as it goes into the sinuses and into the venules. So that it would also be consistent with pressure distribution that I've just described. Here's an interesting image from Singh and Zamboni. I like this one a lot. You see here an obstruction down at the confluence with the subclavian vein, and it produces not only a narrowing there, but another stenosis up here. And that stenosis would be associated with a lower pressure region, as I've shown here. And notice that often it's observed that if angioplasty is used and the valvular obstruction is removed, then that upper stenosis goes away on its own. And this was the point at which I had my insight moment, my eureka moment. Michael Arata mentioned that in this circumstance, you often see that secondary stenosis goes away. And that was the thing that caused me to think, well, it sounds to me like that's just a standing wave that you've gotten rid of by clearing the obstruction. Now, let's have a look at what the impact of venial hypertension is on the blood flow through the capillary bed. First of all, and this is classic law that goes back over 160 years, Darcy's law says that if there is a reduction in the pressure drop, it's going to reduce the amount of blood flow. Of course, the reduced blood flow is also called hypoperfusion. And another law called Fick's law. Hypoperfusion means that there's going to be less blood flowing per minute through the capillary, means less oxygen, less glucose. That means that there's going to be less of those things to transport into the brain tissue. So it's going to lead to hypoxia in the brain tissue and a deficiency of glucose and other nutrients. So those two things, hypoxia and hypoperfusion, have been widely observed in MS. Now, I'd like to be able to take time to go through each of these papers in a little more detail, but I just give you some of the names of the key authors here. Of course, too, it's widely reported that hypoxia is associated with patient fatigue and decreased mental acuity. Also, it's shown that hypoxia is associated with the destruction of the oligodendrocyte cells. With that destruction, that is going to give rise to demyelination, which of course the oligodendrocytes, their prime function is to support, maintain, and grow myelin, and when they are removed, the myelin is going to deteriorate. Also, backing up a little bit, hypertension can lead to a disruption in the blood-brain barrier, and that has been discussed in a number of places. I've given one of the sources here. And if indeed there is a disruption in that barrier, it would occur at the venual end of the cerebral capillary bed. And that is associated with the absence of smooth muscle and surrounding tissue and so on. So, with the disruption of that barrier, iron and lymphocytes may enter the brain tissue and give rise to the autoimmune attack on demyelinated neural axons, and that's been reported in a number of papers. So the impact then, let's look at the impact of hypoxia on the endothelium. The endothelium is the thing, of course, that makes up the blood-brain, or is a major component of the blood-brain barrier. Hypoxia gives rise to a reduction in endothelium compliance. So it becomes less elastic, it becomes stiffer. Hypoxia also leads to the increased adherence of leukocytes to the endothelium. And hypoxia also leads to increased endothelium permeability and endothelial cell destruction. In other words, the hypoxia is going to weaken the blood-brain barrier. Also, hypoxia can reactivate a dormant Epstein-Barr virus, and hypoxia also triggers angiogenesis, or the growth of those collateral veins. So all of these things are consistent with MS and are measurables in MS. So what now is the impact of reducing the compliance of the endothelium? Well, if those veins are less elastic, less compliant, it means that they'll have less ability to store reflux blood pulses. That blood then is going to be stored more easily in a more compliant vein than in a less compliant vein. What that means is that it'll force more blood and more pressure back up into the venules. So less compliant means higher hypertension in the venules. And that gives rise to the increased risk of disruption of the blood-brain barrier, and of course that is going to increase MS risk. So what are the factors that reduce vein compliance or increase the endothelium permeability? Well, being female is a factor that is associated with less compliance. Compliance in the female vein is about 50% less than in male. So you would infer from that likelihood of increased pressure in the female and then in the male up in the venular region. Vitamin D deficiency increases or causes the compliance to reduce. Other factors like cigarette smoking, consumption of coffee, other dietary influences like gluten also tend to reduce vein compliance. Epstein-Barr virus not only reduces vein compliance, but it also increases the permeability of the endothelium. Also, aging and genetics are related. So then the big question is, how do those factors affect venular hypertension and hence MS risk? Well, the answer may lie in the use of computational fluid dynamics, and I thank Dr. Markle for raising the issue of Navier-Stokes so that I can now step into that area as well. The Navier-Stokes equations in one formulation look like this. This just comes out of Wikipedia, incidentally. And they look a little more complicated than they really are. This is just a form of force equals mass times acceleration, which is Newton's equation. And you'll notice that we have velocities on the left-hand side of this equation. And I've got the velocity over on the right-hand side. I've got mass is mass per unit volume, density, rho. And I've got other factors like gravity forces and so on that would come into it. So this brings me back to the future of 4D MRI. And one should be able to measure these velocity vectors. One should be able to make estimates of things like compliance, enter the gravity forces. You probably want to measure this 4D MRI, both supine and vertical. But that allows you to then solve for the unknown, which is the pressure gradient. So through this, one should be able to get a non-intrusive measure of what the pressures are, pressure gradients in the vein at least. Then you would have to do some extrapolation through modeling of what the pressure would be in the finer venules. And this, I think, would throw considerable insight into the entire mechanism behind MS. I've got one more slide, 1 minute and one slide to show the links. Start with venous obstruction, which may be from a number of causes. That's going to lead to venous reflux. In some circumstances, that will lead to venular hypertension, hypoxia, which is associated with collateral growth, fatigue, and brain fog, oligodendrocyte cell destruction, and demyelination. Hypoxia is also going to be associated with the increased adhesion of leukocytes to the endothelium. And hypertension is going to be associated with barrier disruption. The strength of the barrier is going to be a function of the endothelium, and that in turn is going to be modulated by other factors like diet, vitamin D, sunshine, smoking, Epstein-Barr, gender, genetics, and one or two other things that I haven't shown here like trauma. Even electromagnetic radiation can cause a disruption in the blood-brain barrier. But with the barrier disruption, provides the opportunity for iron and leukocyte transport into the brain. And so the leukocytes there see demyelinated neural axons, gives rise to inflammation and scleroses. Now, to get to this bottom point, there are two starting points. One is the venous obstruction. And my reckoning from my reading of the literature is about 85% of MS patients have this route. The other starting point is just a wonky endothelium. And that basically is the set of links which tie together the obstruction and the development of scleroses. I want to thank several other people as well. Mike Arata, not only for his suggestion of writing a paper, which I have done, and it's appeared in the December Journal of Medical Hypotheses. And I want to thank Mike as well for quality of life change he made for my son. I'd also like to thank Marian Simka for suggesting to me the Medical Hypotheses Journal. At this point, I guess I'm ready for comments and questions, and I'd like to start the ball rolling by asking anyone if they can measure my hypertensive points without causing a change in the nature of the obstruction, which may cause a reflux.
Thank you very much.
There may be an answer. Sorry.
Oh, sorry.
Please go ahead.
Oh, sure. Trevor, that was fantastic. As you know, there's two things I love, fluid mechanics, Navier-Stokes equation, and MRI. And indeed, we actually can do that. And the person sitting to your left is the one who knows how to do it. But it definitely can be done. And I think it's actually one of the most important things to come out of this meeting, believe it or not. But I actually had one other question that I want to ask you. As we talked about the nodes, we're actually going and beat normalizing to the cardiac pulse, and we're actually showing a pressure drop about, roughly 5 to 9. One of the things I was kind of wondering is, we are beat normalizing. What happens when you throw respiration in there as well, right? You're looking at a plus or minus 12% or 12 millimeters of mercury. Imagine that pressure wave. It's like a tsunami.
Yeah, my perception is this, that some exposure to digital signal processing is called for here. There is a technique called Kalman filtering, and you can set into your data a means to sort out the influence of respiratory and the influence of cardiovascular, so that these can be separated from one another, even though one may be substantially dominant in terms of the amount of power that it contributes to the process.
Yeah, well, I was actually thinking more of like the shock wave that's actually going all the way back up into the intercerebral veins, right? Because one of the things that we've seen, Dr. Schelling showed, is that you actually start to get that serpiginous pattern, right? Like when we actually get that venodilation with that back pressure with now 2 shock waves, effectively what we're getting, right? Like the power of that's going to be enormous.
Yeah. Well, my son wondered whether or not playing football had an influence as well.
I think that's actually a very good comment. I mean, you'll have, I mean, your heart rate will change considerably if you exercise, if you're not exercising, even during rest, if you have eaten or not, or something like that. So, I mean, you mentioned that in order to get these high pressure regions, you need to have a length of the vessel that's kind of divisible by the half of the wavelength, essentially. But that will change depending on the heart rate, as I understand.
Absolutely.
So you could probably even say that for a specific range of vessel length, you're probably at risk. I don't know if you want to comment on that.
I believe probably that hypertensive region is going to move in and out of the venular region depending on what your heart rate is, depending on whether you're exercising or not. So it's not going to be steady, continuous. It'll be dependent on, you know, what your rate of pulsation is and so on. Anything else?
Great, thank you very much. And we'll go on to the last presentation. And Vera Steshkel, from professor at Stockholm with some background in immunology and toxicology, is going to talk about, I guess, the effects of metal in the brain and how this relates to what we've been discussing. Vera.
Thank you, Mark, for kindly squeezing me in between the distinguished speakers. Dr. Marklein, thank you very much. My lecture is an extra bonus for you, so you don't have it in your books, and Bill is now distributing abstract for my poster. So for those who might think this is interesting, so please do visit me at the poster tomorrow as well. So I am immunotoxicologist, and first of all, I would like also to thank to my colleagues in Mediterranean Hospital in Greece, who actually raised this question for me. It was a very beautiful story because they said, well, we get these people healthy by PTA, but it doesn't really fit into the screen which neurologist says that it's autoimmune disease. And I looked at him and say, doesn't it? It makes a perfect sense for me. So if you can present what you do, you beautiful things, in the context of the accepted scene that MS is perhaps immune-mediated disease, neurovascular immune disease, maybe this will facilitate the process. So let's look what I am going to say. So I have been very keen to learn, and I learned, and I hope you understand and you agree with me, a few facts which are the common knowledge, that in people with MS, but also with other diseases, both neurologists but others, you have restenosis, stenosis, you have inflammation and plaque formation centered around veins, you have deposition of iron in basal ganglia, and you also have the presence of iron-laden oligodendrocytes, which are certain type of macrophages adjacent in the endothelium and in the brain. So the question is, and it remains, we are at the beginning, and I am proposing this as a sort of hypothesis, which are supported by the literature and by our own finding. So restenosis, what do we know about that? The literature is very contradictory, but there are data published in distinguished papers, for example in Lancet, showing that hypersensitivity to metals in the stents might be one of the reasons for triggering stenosis. And it has been described for stainless steel, nickel, cobalt, molybdenum, and for gold stents in the heart. So restenosis has been triggered in people who has been sensitized to gold and have been plated or stented with gold-plated stents. You have to take this for granted, and this has been now for 20 years. Gold is not inert. It's shining, but it's not inert. And actually people treated with colloidal gold, 40% do develop side effects after colloidal gold. So the use of gold-plated stents has been disconnected because there has been very high incidences of stenosis. And how do you get allergic to gold? Through your gold dental fillings. So what sort of allergy is this about cellular type hypersensitivity or metal-induced allergy? You can't see anything in antibodies. There are no IgG, IgM, IgA, no. This is cell type hypersensitivity triggered by the T cells. And more on the things how you diagnose by patch test or by so-called in vitro blood test, LTT, lymphocyte transformation test, or ELISA test. You can either read in brochure, which will be deposited at Mark's place, or at my poster tomorrow. What you do, you can actually determine the individual sensitization to metals, but also to other agents like gluten or drugs by the blood test. So the second things, Dr. Zamboni and many others before showed completely clearly that there is an inflammation and plaque formation around the veins. This is very interesting because what it implies is that transporters of the metal debris or iron from outside the brain through the blood-brain barrier can cross into the brain and deliver this. So what you see here is macrophages, which is laden now not by iron but titanium dioxide, which is a very favorable or very often used additive in drugs, vitamins, foods, toothpastes, chewing gum. And this is how it looks. It is biocompatible, so the macrophage is laden. It will not die, so that means it can go through the limbs and through the blood, cross the blood-brain barrier, which is often damaged, and of course damaged in MS, into the small veins. And there, the macrophages will die, the debris will be released, and oligodendrocytes and other glia cells will crowd there and say, gee, this is something we need to take away, because that they won't do. They are actually scavengers. So they do that, and they are, of course, laden by these things. And in the process of that, they will be killed. And this is one of the possibilities why then oligodendrocytes die, and there will be no myelin, because they do myelin, okay? They produce myelin. There is another parallel, and this is exciting what Matt said about Parkinson, because in the Parkinson's you have something which is very similar. In substantia nigra, you have this black matter due to neuromelanocytes. And neuromelanocytes are another types of macrophages. And when you are born, neuromelanocytes are completely without color. And then with the time goes on, more and more oxidized oxides, it's accumulated, and as well as in MS, neuromelanocytes are now producing dopamine. And what Parkinson is about, the lack of the dopamine in the system. So the third thing, deposition of iron in the basal ganglia. So, for some reason or other, I was part of the group which published this little paper, 1995. And we have looked on 34 patients with CNS and systemic symptoms which resembled heavy metal intoxication. In this case, there were people who had a lot of dental amalgam in the mouth. And then there were 120 healthy controls. And it has been done an MRI, I think it was two-weighted MRI, and it has been clearly found that most of these people who had a deposition of iron in the basal ganglia, which was not found in actually any of 120 controls. And at the same population, there have been done this lymphocyte proliferation, and we have found and we have published that people with this abnormal deposition of the iron in the basal ganglia had also statistically increased memory cells to different metals, among others mercury and nickel. So this study has been then later on consecutively updated, and so far we have about over 100 patients with MS, and we have sex and age match controls, 144, and the results are that what we have published many years ago stands, but they are more metals, which there is a significant difference in the inflammation induced by different metals, among others gold, palladium, lead, titanium, nickel, and mercury. So since we have all these things, where do we get them? It's not only dental fillings, but this is the major part. You also have it in cosmetics, you have it in vaccines, you have, of course, in the air, in cigarette smoke, and there is also prenatal exposure. So for some of those who dare to look into your patient's mouth, that's how it can look. And to do it even more scary, this is oral yield of one single patient. Very often these patients have corrosion, they have batteries in the mouth, that means they have dental amalgam, they have gold, they have titanium, and any sort of engineer would tell you this is no good, can't be good. So the situation goes that FDA, Food and Drug Administration, about 1.5 years ago, reclassified silver fillings, which is dental amalgam, from safe for everybody, safe for many but not for all. And people which should not have silver fillings in the mouth are those with allergy to mercury or any other metals in their mouth. In Europe and worldwide, UNEP, United Nations, has now decided to ban amalgam before 2013. So it's gone, and if you can determine or if you suspect that your patients might have allergy to mercury, you should, according to FDA, take up the contact with the dentist. Dental metals in human body, this is through Dagmar Magnusson. It is a Mendeleev table, which everybody, of course, knows. And the middle part of this Mendeleev tables are so-called transition metals, starting from titanium, going to chromium, nickel, copper, and mercury. And these guys are very frequently used in dentistry. And why are they called transition? They are called because they are unstable and they have one single electron in the orbit, and as you know, electrons go always in the pairs. So these guys are looking for another electron to make an electron pair and to be stable. And where do they get it? They will get it in sulfur-rich protein, amino acids in your body. This is just another source of different metals. We can pass this. And let me see. And this is so-called altered cell hypothesis of autoimmunity, has been coined many years ago by Ernst Gleichmann, saying that if you have transition metal exposure, they will bind, because of this electron thing, to your own cells through SH groups, but also other groups. And by this, they will change the structure of autologous cell. And in certain genetically predisposed individuals, it will trigger immune response and autoimmunity. And the cells tagged with metals will be killed. So if you inject a little mouse with a little bit of mercury, and which is radio-labeled, and then 2 days after you are looking where this mercury homed, you will find it in myelin in the brain. It's so-called retrograde transport. Yeah? So that means that there are definitely effects in the brain which are coming from periphery. And there is a vast literature in animals showing that depending on the genotype, You either are responding to this or you do not. So you might be a responder, you might be non-responder. So this is not the toxicity, this is low-dose chronic inflammation or allergy. Keep it like that. Very recently, many data has been summarized, and this is a review of Houston, which I strongly suggest that you read, from Vanderbilt University here in America, showing that what mercury can do to vascular system. So, and he even gives advice that any person with vascular or cardiologic disease should be asked for the exposure to mercury. I would suggest not only mercury, but any other dental metals. So we have to ask the question, can it be a common denominator within different diseases which show vascular aberrations, chronic fatigue, and other things? And yes, I would bet, and our 15 or 20 years of clinical studies which we have done points into this direction. So continuation can be tomorrow, and if you have any sort of questions or worries, please look on our website or write to me. Thank you very much.
Yes, Hector.
Congratulations for this work. I think this is fascinating. And I have a question for you. Do you have any experience on cobalt? And then I will tell you why.
Yes, we do, because cobalt is part of the stainless steel which is used in implants, but as well, unfortunately, as in dental filling, so-called metal-bound porcelain. And it's deemed to be one of the most sensitizing metals after chromium and nickel. We did not have so much success to show real allergy to cobalt in vitro, and we think that the skin reaction due to cobalt in patch tests are more toxic than allergic. However,
correct,
we know that cobalt is cardiotoxic, and there is something which is called cobalt heart toxicity, and I would love to, if somebody would have such patients, look if there is inflammation or toxicity.
It's very interesting because I had the privilege to work with Julio Palmas in his basic science lab. And briefly, what we did is we exposed endothelial cells to different metals. And we were looking for an answer for restenosis inside the stents. And what we did is we exposed different metals to endothelial cells, and it was striking in what we did. Unfortunately, we never published this, but the two metals that we could definitely find that pretty much killed endothelial cells were gold and cobalt. It was very, very striking.
I'm surprised by gold, but I am not surprised at all about cobalt. The other very toxic metals which you don't realize, but they are used in dentistry, it's thallium and indium. They are extremely toxic, but you do find them in dental fillings.
Congratulations. I think it's a fascinating work. Thank you very much.
Vera, thank you very much. And I am delighted to tell you we are on time. So we have a nice coffee break until 3:30, and we'll see you then. Thank you.